Welcome to today's webinar. My name is Blake Baucom and I'm the Director of Sales for Osteogenics. Before we get started, let me address how we will be interacting today. From a technical perspective, we can't hear or see you, but we would love to hear from you and be able to answer any questions that you may have. There's a question and answer button on the right-hand side of your screen where you can type your questions at any time and we will try to get them answered during the webinar. Let me introduce the man that needs no introduction, Dr. Sascha Jovanovic. He was formerly trained in periodontics at UCLA School of Dentistry, in implant dentistry at Loma Linda University, and in prosthodontics at the University of Aachen in Germany. He also holds a Master of Science degree in oral biology from UCLA. Dr. Jovanovic's clinical research emphasizes aesthetic management in dental implant therapy and applied bone and soft tissue reconstruction techniques. He presents and teaches his implant protocols globally and is academic chair of the Guide Institute, assistant professor at Loma Linda University, past president of the European Association of Osseointegration, past co-director of the UCLA Dental Implant Center, honorary member and award recipient of several academic organizations and editorial boards for scientific journals. His multidisciplinary dental practice is based in Santa Monica, California, and he restricts his clinical work to dental implant therapy, bone and soft tissue reconstruction, and aesthetic dentistry. Dr. Jovanovic, thank you so much for your time and being here today. You and I have worked together for, it's been 10 years or so now, so I'm really looking forward to hearing the presentation today.
Thank you. Blake, it's a pleasure for me to come to all of you here with this presentation. We're here in Los Angeles at this moment. It's about 4 p.m. LA time. And we had a normal day here in the practice with patients. We had academic work. So this is a great time to finish the day. And Blake, the request that you had and Osteogenics had, and of course the invitation, is very kindly received by me, because I think that talking about like a very simple topic is so important sometimes. So like the topic of sutures really can help us in every day. I just see so many times incision openings. I see inflammation in tissues because of the type of sutures which are being used. I see needles which are too large, so you cannot really anchor them to the correct periosteum. I see sutures, utilized in areas where they're tearing through the tissues, and again, inflammation happens. So I think it's a very good topic. So let's start with the topic, and I'm just gonna give you a moment to look at where my home is, so to say. This is the Guide Institute and the Guide Dental Center. And we're based in Los Angeles with normally very, very lucky weather. But this winter has been absolutely a very challenging winter for Southern California. In some respects good, because of the water shortage, but in some respects very poor. But I think spring is coming, so hopefully we're gonna get out of this. Here I can just give you two of our top programs which we offer to dentists in North America, but also around the world. Basically, one is our top-end program, which is a modular 1-year comprehensive implant program, where really dentists go through training in a way that is very comprehensive, and it goes really very evidence-based, but still very practical. And they learn really what are the top steps in implants. And secondly, we have a very user-friendly video library, which has been going on now for many years, and it gets uploads of new controlled videos every week, which is the Guide Video Library. So please have a look at that, and between any of those two, you'll be able to really satisfy your needs of either clinical or academic or combination of both. Now to the topic. So what does suturing mean really in general terms? So we have to remember that really when we're trying to suture in any type of work that we're doing, could be periodontics, could be implant dentistry, could be oral surgery, could be even endodontic surgery. It's really the goal is, first of all, to have an idea and a concept to place the flap and the tissues in exactly the position that we need it for optimal healing. And of course, we need to do this without any kind of tension. So it's really, really important to do this. many times clinicians make a mistake, and this is like sometimes like you have to think about that. It's like suturing, of course, is utilizing a material which is not optimal for tissues, right? Because we're going through the tissues with a needle, which is already trauma, and we're also putting a material into the tissues which possibly is not really optimal in kind of biocompatibility. So, and then you're putting tension on it. So let's say suturing, less suturing is more healthy healing. So this particular slide was just more like of a fun slide because many people like sometimes over suture a site. So maintain always the health of the flap and maintain maximum vascularity. So like utilize the proper needle, a small needle. Utilize the proper suture material, so minimal inflammation. And of course, use a technique which is minimal tension. So like really always think about vascularity in your flap. Now, some parts of suturing technique which are really, really useful is the following. And that is that, we have an idea that you have to remember to really do for sutures. Now, this is kind of, I can't see this. You have to like always, I can't see this. Okay, perfect. I can see. You have to always make sure that when you have a flap and before you're suturing, the flap content has to be really, again, maximum vascularity. So there should be no, bone particles there. There should be no soft tissue particles there. Before you suture anything, it needs to be clean. So I use, for example, in flap management, always the maximum amount of irrigation that I can do and that we can control to get rid of any kind of side materials. Then place the flap again in a position that's desired. So what do you want to do? Do you want to move the flap in a coronal direction, or do you want to move a flap in an apical direction? So two different motions that we're trying to do. But we don't want to have any tension. So we always are very, very careful about releasing a flap so that when we're suturing it, we're not putting tension on it. So flap management is crucial about suturing. So it's like, you really have to think about that. Then when you're looking at adding a suture technique, so just strictly thinking about the needle, you always want to go with that needle at a direct angle to the flap. So that's it's like you almost have to think about a needle being a straight needle, which just goes straight through. Because the more you go at an angle, of course, the more the bevel will limit the thickness of the tissue, and the more, of course, technically and biologically speaking, it's going to be a problem, and it could tear through. So really think about really always direct angles. Another problem which often happens with suturing is that, people take a bite of the flap, which actually is really too small and too short to the incision. So now the problem is that you're going into that bite, and when you're putting a little bit of closure or a knot on it, you can pull through it. So I have kind of this minimum distance, which I like to keep, which is 3 millimeters, 3 to 4 millimeters away from the incision margin. So that's really helpful. Then another top priority key point is do never place a knot on top of an incision. Because again, with the thickness of the knot and possibly some bacterial content, that can move into the incision and then can give you an inflammation. So suturing has just some of these basic, simple principles. And again, closure with no tension. Then let's go to the types of sutures. I think it's okay. Yeah. If you could just keep it here, let's go. Yeah. And move it a little bit down. No, just the top. Yeah. Okay, perfect. Yeah. Okay, now let's talk about the type of sutures. I'm going to go a little bit more technical and want to see if I can help you to go through the jungle which is out there. So I've done a couple of posts on social media on Guide Dental, and I think it was also shared on with Osteogenics about suture materials. And so this is kind of a repeat of that. So if you want to see more of this, you can go on the social media sites of Guide Dental and of Osteogenics. So basically we have two types of sutures which are important in practice. One is, of course, the non-resorbable type. Other one is the resorbable type. Now, when you're thinking about non-resorbable, when do I use that? So predominantly, we use non-resorbable sutures for implant placement and for any kind of GBR or bone grafting or sinus grafting. So any type of hard tissue grafting and any type of implant placement, it's mostly a non-resorbable suture. So then we go straight to the resorbable suture. Like when is that indication? So usually, and that's more in most of the cases, like when I say most, I would say 80 to 90%, it's for mucogingival surgery. So anytime you're going to do any kind of periodontal, flap procedure, anytime you're doing any kind of soft tissue procedures around implants, a mucogingival procedure, let's say uncovering or any kind of grafting of soft tissue, it's resorbable. Okay, so that's already distinctively different. Now let's go back to non-resorbable. So you're doing an implant placement, you might do also a GBR procedure, and you're now going to close the flap. The two top sutures that you want to use here, and I'm going to exclude everything that you don't see here because I personally don't use them. So the top suture that I'll use for implant placement and for GBR is a PTFE suture. And of course that has the trademark of Cytoplast, which of course why we're doing the webinar today is with Osteogenics. Then the second one is you can use nylon. And we'll go a little bit more into nylon because there's different type of nylons out there. You have the generic type of nylons and you have the more trademark nylons, which are more premium. So again, one trademark that I like to use is the Resorba one. And that one is like a very good company who makes really premium nylon sutures. And we'll go a little bit more into that. So these are just like generically speaking. Now let's just stick to this here. PTFE or nylon. And usually I use PTFE for like flap closures, which have more thickness and have more like, coverage. So you need to cover like a lot of implants, or you have done implants with a bone graft, and you need to really have a suture there which is going to hold that flap together because there's a lot at stake here because you have a big bone graft underneath, you have multiple implants underneath, and you need to keep that incision really close. So PTFE is probably the best suture that you can do for your patient. Nylon is the advantage is it's a little bit smaller, a little bit thinner, has smaller needles, so they're usually good for like thinner tissues when you have maybe like a papilla you have to close or some soft tissue. So that really works well. Now let's go to resorbable sutures. So you're looking at like mucogingival surgery. The most known suture is probably Vicryl or gut. I'm not going to mention gut because basically that's like a material that is not being used or recommended for like, really detailed surgery because there's so much inflammation with that, so we don't use that. So I personally don't have it in the practice. Now Vicryl is a good suture. It's more stable, but you have also these other sutures which are polyglyconate, and they're like a little bit less inflammatory, and again they have been made in such a way they can be monofilament. So my preferred suture for resorbable is not a polyglycolic acid one, which is more braided. Mine is like a polyglyconate, which can be made in a monofilament, which again is much better from a plaque, type of accumulation. Now let's talk for a moment about like the management of the suture. You need, of course, a good needle holder. So the one that I use is a Castroviejo. I have with Eufridi and Dr. Jovanovic instrument kit, so you can just look that up. And there's like, several instruments there, but I want to focus mainly here on the needle holder for the suture because it's really difficult to do high quality suturing technique if you don't have a good needle holder. So there's several of these. You have like, thicker Castrovejos, you have thinner Castrovejos. Depending on the needle size that you're using, in most surgical kits, you probably have a good need for like, a medium one where you can do like a 4-0 or a 5-0 suture really works well. But it's really important that you have these type of needle holders. Now let's talk about suture sizes because there's a lot of confusion, right? Like even in my office, which is very specialized in surgery, sometimes there's boxes missing or needles are missing, and then I have to get on the phone very quickly with Osteogenics or with Blake and say, hey, I have an emergency. I need like some special sutures. And Blake, I'm sure, is smiling at this moment because he will kind of know when this happens. So let's try to prevent this. So basically, we're recommending anything between 3-0 and 6-0. Any of those sutures are really good. And so that's kind of your main target. That's the range. Now, you're probably going to use most often somewhere in that 4-0 to 5-0. Now, I have a particular indication for 3-0, and that is like the incision closure after GBR, where I use a 3-0 or 3-0 Cytoplast suture, because that's really an amazing suture, like an excellent suture from a standpoint of like, flap management, closure. 6-0, just to go to the other extreme, is really a beautiful suture because it's a smaller needle for like when you have thin tissues or when you're closing a papilla. So just remember always, smaller suture sizes are great because they're really thin and easy to manage through the tissues, but they have no or minimal tensile strength. So if you are like, very kind of manipulating the tissues a lot and you're pulling too hard on a knot, it will break. So you really have to work very fine with this, and you have to have a high dexterity to do this. But like, when you do mucogingival surgery, usually it will go to the 5-0, 6-0, sometimes even 7-0. So the larger sizes really cause a little bit more trauma, so you have to do it in flaps which are thicker. So that's why I said 3-0 and 4-0 are more like for thicker flaps. Now let's talk about needle sizes. Also really, really important because many clinicians don't really pay too much attention or don't really look at that too much. But you have to remember that the needle size, so the curve, has a certain length. So the smaller sizes, let's say a 10 millimeter, have shorter bites. So when you, for example, have very thin tissue and you have maybe some periosteal tissue, it's really nice to go with a small needle through that area because that's kind of gives you like a quick turn, and also there's very little trauma to the tissue because it's so thin. But obviously a 10 millimeter thin needle is not going to be very helpful when you have a thick flap. So that's why we then use like the longer needles, like a 13 or even 16 millimeter needle. And of course these numbers vary a little bit, but you basically have to always keep in your mind, you have short needles, which are really for mucogingival surgery, maybe for periosteal suturing, and I'll give you some examples. And then you have the long needles if you're having a full thickness flap. And the larger size, of course, have a long bite, so you can go through thick tissue and you can do full thickness flap. So that's really helpful. Now here, a look at a PTFE. So this is like a suture which is really important to me, and I use this on a daily basis. It's number one, I would say it's monofilament. Number two, it's inert. So there's really minimal tissue inflammation. And it's also like a little bit elastic. It gives you the potential to tie the second knot, sometimes even the third knot. So it's a very, very user-friendly suture. Then it's also a very patient-friendly suture because it's very, very soft. So I can have sometimes sutures on the palate or in the crestal area that like you have like minimal trauma to the patient, and it can stay there for 2 weeks or 3 weeks. So therefore, in my office, I remove sutures after 14 days. So it keeps it really, really comfortable for patients. And yeah, they sometimes will say, oh, can I remove the sutures? Feels better. But it's nothing like, you see with these, big sutures that you see. So Cytoplasm is my go-to and definitely something that will change your life if you haven't used them before. Okay, nylon is also a great suture from a non-resorbable perspective because it's also inert, it's monofilament, and has very minimal to no tissue inflammation. So that's great. But there are some consequences with this one and some drawbacks because it's kind of a little bit more rigid. It's not as soft as a PTFE. And especially when you're going to the bigger sizes to hold a bigger full thickness flap, they can really be like irritating the tissues. So usually, these sutures are not as soft as PTFE. So we don't use them in a larger size. Let's say a 3-0 or 4-0 nylon is not my preference. And they also have sometimes, depending on what kind of suture you're using, you can use nylon like a generic type. They have this wicking that it goes through like, like a wave. And it's really hard to manage. So it's not something nice to work with. Now the good news is, when you use the premium nylon like Resilon from Resorba, they actually are really produced that it comes almost like in a straight suture, which is like almost like a straight hair. So it's really easy to work with. So and they're also a little bit softer. So it really helps you if you like to use nylon, and I like to use nylon, for example, for vertical incisions, to use a material which is more premium and it doesn't have that much memory and is still soft for the patient. So here's just kind of a summary of this here. So you got the non-resorbable sutures for implant GBR, PTFE cytoplast. You can use general nylon, so it's a polypropylene, but not probably recommended by me. And then you have the premium nylon, which I would recommend, which is the Resilon or from the Resorba company. Then resorbable sutures are good for implant mucogingival work. So again, you can use something like, Vicro, very generic, polyglycolic, but it's like a polyfilament, so there's a lot of wicking. So again, I don't use it in my practice. So as an opportunity, as an advancement and as an improvement, you can use like a polyglyconate or a Resorba, which is more monofilament, so it's more inert. So this is kind of my go-to when I look at sutures to work with. Now, again, this is just going the visual of the boxes. I mean, it's a very traditional type of like, suture material, comes just in a package, sterile, and you can use this. And I just here for completeness, I'm also adding here, like, for example, a Euphrates suture. But, these sutures are also good, but they're more generic. So they don't have that premium quality that, for example, the needle is really like, attached in a very unique way to the suture to the needle, and that both the needle and the suture are premium made. So, but of course, it's always good to have these opportunities and these options in your practice. Now, here's a little bit of the suture sizes. So look at this, what we're recommending. So usually for nylon, I would recommend like a 4.0, 5.0, 6.0. So probably more to the smaller size, even a 7.0. For the PTFE, I would go more to a 3.0, 4.0, maximum 5.0. Although you can go smaller, but it's I like this differentiation. So just remember, the more you go to a smaller size, so 5.0, 6.0, 7.0, the tensile strength is going to be weaker. So you have more potential when you're tying the knot or when you're pulling on it that it will fracture. Then needles, there are some round ones, so half size. It makes a really quick turn, but it's not something really like that we use in oral surgery or periodontal surgery or implant surgery. We usually use the 3/8. So pretty much every suture that I have in my practice is a 3/8. Then I mentioned this already. You can go with small needle size to large. So you got to have a variation. I mean, obviously a 13, somewhere in the middle of the range is going to work for many, many indications. But, I run into these situations all the time. I want to pick up some periosteum or have a really thin papilla. I want to have a small needle. So it's good to have this as a backup. So I would always recommend to clinicians, have, of course, enough suture material available in your practice for the middle range, so the 50% that you're doing. But you got to have something larger for those 25% on the outer range, and something smaller for the lower 25%. So that's the 10 or the 16. This is a suture I talked about. You can have round needles, but usually round needles are not really that effective when you're thinking about keratinized gingiva. So basically everything we use is reverse cutting. So reverse cutting is really the norm, and that's what we have. It prevents the tearing of the flap. And again, as I mentioned, you have these different sizes which can be attached to this. So then from a knot standpoint, many questions always come up like, hey, is 2 knots enough or should I do 3? And I do 4. I started doing 4 knots really traditionally, really with PTFE sutures, because they have this beauty that at the first knot, when you're tying it, obviously it can loosen a little bit. But you can still tighten it with the second knot, which is basically that looseness. You can even tighten it with a third knot. So I keep that 4th knot in there just for security, and I don't have really knot loosenings. I prefer a surgeon's knot, different ways, but 4 knots is important. And I think that in the community, the 2 knot type of history really comes just from the old days when silk sutures were being used, which we don't use today anymore. And just that it was just like you lock them, they're locked, but they're very difficult to manage. Nylon, I do the same thing, 4 knots. It's really 4 turns, really recommended to have really no loosening. And then there's one more thing that I would like to just mention here from a type of suture cutting. Make sure that your team or whoever clips or cuts the suture doesn't cut it too close to the knot, because obviously it can loosen. So I always like the suture to be cut approximately 3 to 5 millimeters above the knot. That really helps me to maintain stability. So let's go into a couple of suturing techniques now. Now, most important for me, when I close a flap just after a normal implant placement with or without GBR bone augmentation is to understand that I need two closures, suture techniques. One is a horizontal mattress, and in between each horizontal mattress, a single interrupted. This will evert my flap, and it will bring the flap margins nicely together. Second closure is, of course, my vertical incisions. On the vertical incisions, I don't really need a single I don't need a horizontal mattress. I just need a single interrupted. Here you can see the horizontal mattress, just for those of you who would like to have a review here. So basically, you always keep the tension away from the flap edges because you want to get this flap to be everting. So you want it to come up. So this is all your coronary positioning. And you always use this in conjunction with an interrupted suture. So you can see here just like a typical cytoplast closure with a horizontal mattress. And this just makes it really nice. Important, of course, is that all the dimensions are similar. So you're looking at entry in the buccal, let's say 3 millimeters from the margin, exit to the lingual or palatal, 3 millimeters. If you're giving a horizontal, go about 3 millimeters and then back in and come through the buccal. So it's really important for us to maintain that width that is optimal. So that's really, really important, and keep those distances in a similar, unique way. Now, single interrupted, they go in between the mattresses, or they can also sometimes be for a one-stage implant placement. We use a lot of tissue-level implants. So like, in tissue-level implants, it's great to have a suture mesial and distal, and just could be a single interrupted. But again, just take a deep bite. It's really important to take a lot of tissue so you have less trauma to the margin. You have less chance of that suture loosening itself. Then here's like a good visual on the left side of a flap margin, which is being everted coronally. So you're moving this flap margin up. You can see a 3 cytoplast horizontal mattress sutures. I always start off in the middle with the horizontal mattress. Once I've moved the flap in a nice way, in a perfect way together, I'll go to the left and to the right side. And then on the right side, you can see the single interrupted sutures. So they're going right in between. And again, you see no knots on the incision. They're all like, either buccal or lingual. Here, a similar visual. You can see here the incision and the flap. Then you see the horizontal mattress. These are all like bringing the flap in a coronal direction. And then between each of them, you can see a single interrupted. So that's really important that you can see how the single interrupted has that visual. Here, just like a combination of different sutures. Notice here how the horizontal mattress, again, is really optimal. Bring the flap and closing that, so that's really good. It's all done with monofilament, PTFE, and then you have the vertical incisions. Then I'm going now to a special suturing technique for the connective tissue graft. So this is one which, if I have time, I'll show it to you. When I go to the palate to harvest some tissue, and I take a connective tissue graft from the palate, again, I like to use PTFE cytoplast. But often when you take a subepithelial connective tissue graft from here, you have a lot of bleeding. And so, of course, clinicians are concerned about this. Patients get really nervous about this. And it's one of the worst things that can happen, really, when, of course, patients leave your office, that they're really anxious and concerned about this. So I have this suture technique, which kind of almost gives you a perfect control of any bleeding. And here you just see one case. So you can see the palatal. You see on the palatal how I took the tissue away. And this is 1 week later. So it was one horizontal incision where I took the connective tissue from internal. And then I placed it in this particular patient on a single implant in the anterior. And I closed it again with a horizontal mattress and with like single interrupted. But now look at the left photograph where you see how I closed with like some compression sutures. These are, again, mattress sutures, which are external, and they're compressing the flap. And you can see that here, where you can see a better visual of this here when you're looking. And look at the healing. And here is the visual. So this is a very unique anchor suture. And I'll just show you, first of all, locate the incision. You see the horizontal incision there? And you see already my PTFE sutures. And there's several videos of this connective tissue harvest, by the way, in our guide video library. So you can review this here also on your own time. But I'm calling this like an external anchor mattress suture, or you could call it an external anchor compression suture. Because what it does, it compresses the flap to the underlying periosteum. And I'll give you some numbers. So the entry of the needle goes here. Do you see the number 1 on your screen? That would be your entry of the needle. And you're taking like a nice big bite there in healthy tissue. Then you're exiting, that's your mattress, right there at number 2. Number 2 is like, just you took a bite. Number 3 will be when you're going at the top with your needle and you're going underneath the marginal gingiva. So you're at bone level with your needle, but you're exiting at number 4 at tissue level. And then you're tied off with 4 knots. And basically, when you're looking at that suture that is between number 2 and number 3, that's going to compress the flap inwards. And that will stop the bleeding if you have any kind of blood vessels which have been opened. And the suture that's between number 1 and number 4 is going to compress the gingival margin. So that's also going to help you to stop the bleeding from the coronal part. I usually start with these sutures in the posterior, so like, let's say my molar site, and then I go forward. And I do probably 3 sutures like this, and the bleeding stops. Most of these patients have no palatal plates because they don't need it. So this is a very, very important suture to kind of remember. And we train this suture in our soft tissue course, hands-on course, to our dentists. And if I have time, I'll show it to you here in the presentation. Another important suture for me to remind you of. So just kind of going back for one moment, I like to use, I can't go back, huh? No. Okay. You can go back? Oh, this one. Okay. Okay. So just to make a summary again, for the palatal connective tissue harvest site, I like to use PTFE. Why? Because I can put enough tensile strength on it so I can compress that flap, so I stop the bleeding. Of course, I can use a resorbable suture here. Of course, I can use a nylon suture here. Not a problem, but I can't put enough tension on it because it will break. And this suture also on the palate has the big advantage to patients. It's so soft, so there is not so much trauma for the tongue. So I like these sutures. There's other options. You can do other sutures, that's fine, but that's why I like it. Now let's go to a type of case that we do very often. It's your foulard case where you're doing an immediate delivery of a hybrid prosthesis. I don't know if you've seen some of the work that we've been doing. It's been on social media at Guide Dental, where we're basically, treating these foulard cases like an all-on-4 in failing dentitions or in denture cases with implants immediately, and then we're printing in-house a full hybrid prosthesis. So, but you got to close the flap. So my strong recommendation here is, make sure, maintain all the keratinized gingiva. So maybe do some nice, simple, small horizontal mattress sutures so you can maintain all the keratinized gingiva. Don't just use single interrupted because you're going to roll the keratinized gingiva in, you're going to lose it. And then it's very important to use resorbable sutures because it's really tough with the swelling that the patient has to remove non-resorbable sutures underneath a hybrid prosthesis. And many of these hybrid prostheses don't have the space. And you don't want to remove the hybrid prosthesis, shortly after implant placement. So here, my go-to is, for example, a 4-0 glycolon suture. Perfect for this indication. 4-0 glycolon. Perfect. Now I'm going to show you like a mucogingival procedure. This is like a case where you have a posterior mandibular case, and obviously there's no vestibulum, there's no keratinized gingiva. So I need to establish here vestibular depth, and I need to establish here keratinized gingival margins around these 3 implants. So I do my mucogingival procedure, which is basically a split thickness flap. I'm apically repositioning the flap, and now I need to suture it. Now we go to very, very unique suture demands. I need a small needle. So I probably will use a 10 millimeter needle here. So I can go to the margin of that flap, which is mucosal, so it's thin, and I can grab some periosteum, which is also thin. And I'm going to reposition that suture, that flap margin in an apical direction. So this will probably be an glycolon 5-0 or 6-0 with a 10 millimeter needle. Something like this, in that range. Absolutely not using a PTFE here. and absolutely not using a nylon here, right? So this is only territory for resorbable sutures, and my preferred one here is the glycolon. Then we move to the next step is placing the gingival graft that I harvested from the palate. So this is a strip gingival graft, as it was published and documented by Dr. Henry Takei from UCLA many years ago. But it's like a beautiful graft, very minimal trauma to the patient, and big effect on increasing keratinoid gingiva. So here you can see how I'm using that. And again here, my go-to suture, because it's mucogingival surgery, is a resorbable suture. So again here I'm using a glycolon. I want something maybe a little bit bigger, so I could go with a 10, but I could go with a 13 millimeter needle, that's fine. And I can probably go with a 5.0 or a 6.0, because I just need to place these sutures to hold this keratinoid gingiva in graft in place. So this is a purely a resorbable case with a smaller needle and a smaller suture size. And then you can see the healing. Look first on the left side, that's about 14 days after. Usually I see patients 14 days later. And you can see the sutures are usually gone between 14 to 21 days. And then you can see the strip graft, how it's healing on the palate. Beautiful. So I'm always like very excited to offer this to our patients. We give them a palatal plate just to be sure, but the healing is really so excellent. And then I want to switch now to camera. Blake, so if you allow me, I'll move more into full screen. We got a few more minutes.
Yeah, absolutely. So we'll switch over now to a hands-on portion where Sascha's going to show the different knots, the different materials, the instrumentation. But we really want this to be an interactive session. So as questions come up, please put those in the chat using that question and answer button that we described earlier. And while Sascha's actually working, we're going to interactively handle those questions. So please don't be shy. Any question is a good question. We just want to make sure that we're doing everything we can to make this a fun and interactive session for everyone.
Okay. So first of all, what is showing right now? Which camera is showing? Just me?
It's you and the dock camera, so both.
Oh, both of them. Okay, good. Okay, so I just want to show you maybe like something on the dock camera so you can see like this is good for me to demonstrate to you. So like here, this is for example a suture that I use a lot from a standpoint of like implant placement and GBR. So this is for my suture 3.0 cytoplast, and you can see the needle, which is a 16 millimeter needle. Okay, so this is my go-to. I mean, this is probably, and I think that it kind of is sometimes sold out because probably many people are using it, but that's my go-to. Then you do have, of course, the opportunity to switch it around a little bit. And you can see a 4.0 and a 5.0, and definitely very useful as well. And you just kind of have to see when is your indication to do this. They both work. Of course, the beauty with the 5.0 is that it gets thinner, and you can also see the needle is a 13 millimeter. I love this suture, so like I will never complain to use a cytoplast or like a PTFE suture. So it's my go-to is for flaps is usually like a 3.0, but I can go to 4.0 and 5.0 at any time from a standpoint of management. Now let's go to the Resalon. So these are like the nylon sutures, and I'm just putting a couple out here so you can see it. Because probably like the most used one, again, from nylon is probably the 5.0 Resalon. And the suture sizes are different. You can see a 13 millimeter, but of course, depending on what you have and what's available, you could probably go to something smaller. Notice that when you're going to a smaller suture size, this is a 16 millimeter, that you have actually here also like the opportunity to have larger needles. This is a 13 millimeter needle. But of course, you can also go smaller. So sometimes you have to be aware of these products, how they are, and what you need them for. So like, it's tough for the clinician because you say to your nurse or to your team, give me a 6.0 suture, but just be aware that there's different needle sizes. So you want to make sure that like you have the opportunity to either just have one particular suture that you like in a particular needle size, or you have to be specifying this here. And then just showing you here, this here is like a really unique suture because it's a 7.0 suture. And these, of course, are very useful like when you have very thin tissue, you're doing mucogingival surgery, maybe you're doing a tunneling procedure, you have a small soft tissue graft. So these are kind of really unique. And these are all nylon. Now, then this is probably the one that I really utilize a lot for like mucogingival surgery. That's the glycolon one. And this one is, of course, the suture that has like, the opportunity to show you the monofilament, polyglycinate. It resorbs in about 14 days to 21 days. And this would be a great one for mucogingival work, the work I just showed you, or like in a full arch case underneath a hybrid prosthesis. And of course, you can go also smaller in size. So you can see a 6.0. But again, remember, the thinner you go, the more you have, problems with this here possibly breaking through. Now I want to show you, I guess, like two sutures basically. And let's go to a model, and maybe I can. Any questions, Blake? Because I can't really see the chat, so you have to help me.
Sure, I don't know if you can. I'll ask you the questions as they come up. One question that we do get occasionally, Dr. Jovanovic, is with the glycolon suture in particular. We hear from some customers that they want a suture that resorbs a little bit more quickly than glycolon. So maybe you could just speak about that resorption profile, and if you think that's something that should be focused on, or you like the resorption profile. What is your answer to that question if people ask you about the resorption profile of glycolon there?
Yeah, I think it's a good question. So first of all, let me just answer it in this way. For me, like a suture should stay in place for at least 2 weeks. So 2 weeks is for me like a really minimum, because when you look at all the research we have with collagen fibers healing, it's like, below 14 days, the tensile strength of collagen fibers is still very low. So you want to leave sutures in for a certain amount of time. So I like that when sutures are stable for about 14 days. So I don't need it shorter. If you want it shorter, then yeah, just cut it. It's not a problem, because like the beauty of resorbable sutures is like, if you cut the knot and you leave the suture in place, it will just resorb by itself. So yeah, I don't see this as a problem.
Perfect. So really, you're trying to get to the critical 2-week time frame, and if it's shorter than that, you run some risk.
Yeah, and you know what? And I really don't think it's patients are having any issues with this here. But like, if you want to go shorter, I would just like ask the patient to come back, or maybe you have a different product that you can find. But like the one thing that I would discourage you from, and I think I'm allowed to do that, is just don't use gut, because you can use gut in like cases maybe like a third molar, where you're just doing a quick procedure. But like when you're doing fine procedures, which are mucogingival, grafting procedures, implant procedures, I don't think that gut has any place in it. Okay, hold this place. Just hold it.
Okay, yeah, great.
So what we're going to do here is we're going to take a model, right? So I have the model here. Can you see the model, Blake?
Yes, we can see it.
Can you see that? Okay, perfect. So what I want to show you, and this is like one of the workshops that we do here at Guide and around the world, when we teach clinicians how to do a connective tissue graft. But I did already the pre-work here. So I just took some soft tissue. I'm cutting it out of here, and here's my connective tissue graft, right? So that's my autogenous connective tissue graft. I'm not going to do anything with it, but I just wanted to do this here. Now, see my horizontal incision here? And as you can see, a lot of blood can come out of here because I removed the graft from here. So what I will use now for this one is probably like a 4.0 PTFE, but I could probably also do a 5.0, but I'm going to just do like for now a 4.0, so it's also like a little bit thicker, so it's visible. And I'm going to go grab it. So when I grab it, I don't grab the needle at the end of it. I always like leave a couple of millimeters free. You can see that? All right, so that's good. And now I'm going to show you my suture technique. So here's like my suture technique is going to come in and go apical to where I remove the suture, the connective tissue, and come out. And I'm a little bit restricted here by the camera, but you can see the in and out, right? And then,
hey, Sascha, sorry, real quick. The question and answer button got closed down, so I think there was some technical difficulty there. But if you have a question, or if you've already submitted a question, please resubmit that so we can get to it. Sorry, good to go now.
Okay, Blake, no problem. Another thing I want to show you, and this can happen in surgery really quickly, is when you're grabbing the needle, don't grab it at the needle point, because you're going to destroy the needle point and it's going to be blunt very quickly. So always take it like a little bit below it, when you're pulling it out. So now I'm pulling it out. So that's my PTFE right there. And now look, I'm just going to show you one suture. What I do now is, again, I grab it, right? And then look, very important, I'm going to go press the flap down where I took the connective tissue. I go into this incision, and I go with my needle down to bone level. So I'm going to grab the full thickness of the upper flap, and then I come out tissue level. See that? So that's my grab right here. Then again, I'm pulling it out. And now what you will see is that in this particular area here, from here to here, it's going to press the flap margin down. You can see it happening already. So that now compresses the outer flap to the inner periosteum. And when you have a bleeder from the posterior there, of course, that's very, challenging, and it's also anxiety, but it can stop it right there. And then I tie the knot, right? So like now I just have to tie it. And as I said, I make a double throw. I tie it, hold it, and I put my knot here at the top. Now you can see what's happening. My second line there is going over the top and to the bottom. So this will close the margin. And then we're going here, grabbing the suture. And now look, it's a little bit loose, right, the suture? But now comes the beauty of the PTFE. I can tighten this. Yeah, look. See that? It's still tight. You can actually see the tension a little bit on the silicone here. The second one, usually when you tighten it, will stay tight. Now I do my third one, and I do my fourth one. Perfect. And now I need to scissors. And usually my length that I want to keep this at is about 3 to 5 millimeters. Done. So let's show that. I can zoom in. Okay, is it in focus? And you can see how I'm pressing. It's actually like the silicone shows it pretty nicely, like how this flap is pushing down, right? It's pushing down. And this one is moving the margin down. So it stops the bleeding from internal, and it stops the bleeding from external. So that's really good. And now, the only thing, this will probably stop the bleeding already in a patient who's bleeding. But if not, then you just put some pressure with a gauze for like a minute, and then you go to your second suture. And let's go here. I'll just change this a little bit, right? So I go with the second suture. And let's go apically again. Same thing. So I go in, and you can see how the flap is opening. I go out. Okay, is that pretty visible, right? And I grab again the needle. Don't grab the needle point. Okay, hold. My team is assisting me here, just so the model doesn't move around. And now look, I'm going to do the same thing. Just going to move the model a little bit. Again, I go into this horizontal incision. I go all the way down. Can you see that? How much I'm pressing it down? Yeah, you can see that. And then I'm coming out. So I go from bone level to tissue level. Of course, sometimes you have teeth there, so most of the time you'll be in an interproximal spot. And if you don't have enough gingival margin, then what you can do, you can run it around a tooth. Now look, now I'm going to close it again, 2 knots. And same. And actually it's very nicely visible here in this hands-on demo. 3 knots and 4 knots. Okay. And then cut. Cut. Okay. Now see the 2? And in a patient, I would do a third one. Blake, is there any questions on this here?
I don't think there's any questions on that. I think the audience is asking, can we see the horizontal mattress suture and just kind of talk about how you use that to avert the flap, if you have a model that's showing that?
I can. I have one more thing that I wanted to do for you. So
Yeah, sure.
I'll do first one, and then I'll do the other one.
Okay.
Just give me a cut. Make a cut from here to here. Okay, full. Okay, look, I made actually, because I did something already ahead of time, so I don't want to not do this what I suppose. I want to show you here an extraction socket, because there's many times like questions about what to do with an extraction socket that you're doing a socket preservation. So I have here a model which I have from Straumann, and you can see here, this would be a potential implant placement or just a socket graft. And now I need to do the socket graft, right? So I did my socket graft already. So actually, my associate here did it already. Placed the bone graft into place here. See a nice job here. And it's at the crest. And now I'm using a cytoplast membrane, right? Our traditional technique to keep everything in place. But now, of course, you want to do a suture. So what is an efficient suture that you can do in a place like this? So I want to show you that. And I usually use either a PTFE or a nylon for that. So I want to use a nylon at this moment. And let's take an 5-0 Resilon. Okay, that's a 5-0 Resilon with a 13 millimeter needle.
Sascha, we have had a couple of questions come in while you've been going. Sorry about that. So one of the questions people are asking is, what tissue forceps do you like to use?
Oh, good question. Yeah. So here's my favorite tissue forceps right here. Look at this one. This is a Ufridi TP 5090. I say, when I say to my team, I call it like, give me my plier with teeth. But look how small these teeth are, right? Very, very, very atraumatic. The handle is not, I would say, the greatest. I would like it to be a little bit more ergonomic. It's still flat, but it works well. I've used this for 25 years. It came from like cardiovascular surgery. And then I have other ones which are smaller for microsurgery. But it's a really important question to really use good, indeed, tissue holders. Okay, so now we go to our closure here. Okay, Marina, if you can hold this again. So I'm going to zoom in a little bit. Focus. Okay, and I just want to show you here a nice and easy suturing technique. So what I do is I come from the buckle. So I'm taking my plier and I'm going full thickness. I don't go through the membrane. So I just go full thickness, right? Again, it's quite a nice bite, maybe 3 millimeters. Then I go over the membrane. So the suture is now going over the membrane. I pull it. And look what I'm doing now. Now I'm going underneath the flap, so lingually. And it's going full thickness to the flap. Don't touch the membrane. And now when I pull it, it just goes right over the membrane. So this kind of compresses the membrane in an apical direction, right? You can see that. It's laying right on the membrane. But now, of course, I want to go over the flap because I need to also get the margins to approximate each other. So what I do now with the next suture, I'll just lay it over. I'll go over this. And I will come again from the external flap, internal. So I go from the outer part to the inner part and come through here. Taking the flap. How are we doing with time, Blake?
Well, I think we're a little tight on time. There's also some other questions that have come in, but I think the questions are really good, so we should try to go a little bit over if you're okay with it.
Okay. You can just ask me the question if you want. Now, I just want to show the suture. So this is really the cool part of this suture. You look, it's an external suture now. And now I'll go let this suture run again over the membrane. And I go inside the lingual flap. And look what it will do. So right now it's going to cross. So I have two sutures which are running over the membrane. and pressing the membrane down. And now when I move this over and I close this suture on the buckle here with one. So it's one running suture. It will move the margins together. So I'm going to tie this off. Can everybody see this? So you see how in one very efficient suture technique. So this is my socket preservation suture technique. And the knot again is on the buckle. And I like to use a non-resorbable suture for this, just like it's stable. Second knot. Third knot.
The question has come in, do you ever place a hemostatic agent on the palate when you're doing a CT graft, something like gel foam?
You can, but it's in the technique that we use, it's not really necessary. So you can. Okay, so look at this suture.
So another question has come in specific to the Castro Viejo that you use. The question is about using the 3.0 suture. So they say that most of the Hufridi Castro Viejo drivers are really rated for 4.0 or smaller. Is there one that you specifically recommend?
Yeah, so if I have, again, if you go into my Hufridi kit list, you'll see there's a medium size Castro Viejo, which you can use also with 3.0. There's also another one, a Castro Viejo from, which is thicker. So it can go with like a 2.0 or 3.0. So you can buy actually different ones. But the one that I have in my kit is like a medium size, and I use it for 3.0 all the time. There's a heavier one, but it's kind of a little bit heavier on the hands. Mine is really kind of, still like really, when you're clicking it, quite light. So it's easy to click. And some of the heavier ones can be a little bit too heavy. Okay, go ahead with more questions.
There, it ends in the SIM, right? It says SIM at the end of it. Is that the one that you're describing?
Yes.
Okay.
Whatever is the one in my kit, yeah.
Okay, perfect.
Okay, so now
another question has come in. So how do you minimize the chances of a coronally repositioned flap losing its coronal repositioning as it heals?
Okay, can you repeat that?
How do you minimize the chances of a coronally repositioned flap losing its coronal repositioning as it heals? So, you go ahead.
Yeah, I don't really. I guess I have to think about that question, but I guess what I'm thinking is maybe just that it will maybe not give you enough coronary positioning. I can't answer that.
Okay.
Okay, so let me show you one. Where's the PTFE suture here? So you asked for the horizontal mattress, and please continue with other questions.
Here, can you comment on suturing a resorbable membrane to the periosteum when doing GBR? Basically the lasso technique or the ribros technique, one of those types of procedures. Basically, we're using the suture itself as the way to fixate the membrane.
Yes, and I like that technique. In my protocols, I use GBR protocol 1, which is basically an implant placement with a simultaneous GBR. And in those cases, of course, sometimes you want to stabilize it. And I use the lasso technique for that. Now, what you can do for the lasso technique, or we call it the sling suture, is that you can use it with a PTFE because it's so inert and so atraumatic, or you could use it with a glycolon. But to be quite honest, because I'm very, very always concerned about inflammation when I'm dealing with regeneration, I like to use a PTFE, and then I just remove it after about 3 weeks. So that gives me more control. But if I would use a resorbable suture, if that's your preference, I would use a glycolon. Okay, I'm just doing here the horizontal mattress. And you can see how I'm finishing it here. I made a small incision here on this particular model. And basically now, I went through the buccal margin, and then I went to the lingual margin. And now you can see here the suture. Let me show you here the palatal suture and the buccal suture. Okay? And now when we tie this, obviously it will move the margins in a coronal direction. So you can see that. I'm going to move that, and look. See that? It's like sending you a friendly kiss, right? See that? So, and you don't need to put too much tightness on that, so it doesn't need to be done. You just want to make sure that these flap margins are going up. So basically, when you're about 3 millimeters apical to the incision margin, you basically get like the margin to go up 3 millimeters. So it's pretty cool. And depending on the size of the flap, you'll do multiple. And I suture this here again with 4 knots. Okay.
So, am I live, Steve?
Okay. So I demonstrated
one of the questions that's come
the
through.
horizontal
So on
mattress.
the horizontal mattress, somebody is saying that on the horizontal mattress, sometimes they see that the suture pulls through on the lingual aspect at times. Do you have any tips or tricks to avoid that?
I would say my main comment would be is probably that you need to take a little bit longer or deeper bite. So, and make sure that you're going through full thickness, because the horizontal mattress is a technique that obviously will call for like good full thickness flap. So like, it's not easy to go through thin tissue, because if you go, for example, through a lingual flap that is really thin, then it will pull through and you can get a necrosis.
Perfect. Well, it's been a great presentation, Sascha. I really want to thank you for your time. I think our audience has had a really good opportunity to learn from you and understand sutures and techniques, all the different materials, the knots, the needles themselves. So I just want to thank you again for taking the time out of your busy schedule to help us educate everyone. As always, it's been a real pleasure to hear you speak and talk on this important topic.
You're welcome, Blake. Yeah. So the only thing I can say is thank you to you guys, because like obviously Osteogenics is always doing a great job in sharing important clinical topics. You're not just interested in selling products, which is great to support the community. And I also want to, obviously invite everybody who is watching here, do go into the guide video library, because there's like over 500 clinical videos. So just go into that, because you can learn so much from this. And I don't know what's happening with this video, but if it's good, we can even see if that can be uploaded to the video library. So please go to Guide Dental and see what training and education is good for you. So thanks for having me, Blake, and see you soon.
Yeah, perfect. Thank you, everyone, for watching. We hope you enjoyed the webinar. We will send out a feedback survey here shortly. And we just want to thank you one more time for spending part of your busy day and busy evenings with us here on this webinar with Dr. Jovanovic. Thanks, everybody. Have a good night. Goodbye.
Bye.